Good evening, everyone. Thank you for joining today's masterclass on hypertensive disease in pregnancy, current status and future concerns by Sir Sabaratnam Arulkumaran. I, Sumita Roy, with my colleague Priyanka Jain from the marketing team of Elsevier India, will be moderating the session today. Before we begin, I would like to tell all the attendees that you will not be able to unmute yourself during this session. Should you have any questions related to the topic in discussion, you can post them in the Q&A tab of your screen. These questions will be addressed by Dr. Arulkumaran at the end of his lecture. And now, it is my honor to introduce you to our esteemed speaker. Sir Sabaratnam Arulkumaran is the Professor Emeritus of Obstetrics and Gynaecology in St. George's University of London. He is the Foundation Professor of Obstetrics and Gynaecology in St. George's Medical School, University of Nicosia, and a visiting professor at the Institute of Global Health Policy Innovation, Imperial College, London. He is the former president of the International Federation of Obstetrics and Gynaecology of the British Medical Association and the Royal College of Obstetricians and Gynecologists of the United Kingdom. He was appointed Knight Bachelor by Her Majesty the Queen of United Kingdom in her birthday honours list in June 2009 in recognition for his services to medicine and healthcare. And with that, I request Sir Arulkumaran to please take this forward. Thank you, sir.
Thank you very much. Good evening to everybody who is attending. First, my sincere thanks to Sheenam Agarwal, who invited me, and for Jane, Priyanka, and Sumita Roy for coordinating this session. So my talk, it will be for about 40 minutes, just to talk a little bit about the current status and future concerns about hypertensive disease in pregnancy. So the objectives of the talk is to see whether you can answer about the classification of the disease, whether the pathogenesis were clearly understood, and how to predict whether somebody is going to get preeclampsia, and current strategies for prevention and long-term consequences. So it's a long list, but we should be able to cover that in the short period. So first we'll start with the magnitude of the problem. It affects about 10% of all pregnant women around the world. Unfortunately, it is a higher incidence in adolescents and also in low and middle income countries. Now, this hypertensive disease includes a basket of conditions, including gestational hypertension. That means they get the blood pressure during pregnancy and that disappears after the pregnancy is over. It could be preeclampsia, which means they get hypertension plus organ involvement. They can get petechial hemorrhage in the liver, kidney, which causes proteinuria, and also sometimes in the brain or lungs. So there's a problem there with preeclampsia. Eclampsia is convulsions due to preeclampsia. Sometimes the preeclamptic state is not identified before the woman has eclamptic convulsions. And finally, there is chronic hypertension in pregnancy, which means the woman had hypertension beforehand due to an endocrine problem or renal problem, and that lingers on during pregnancy as well. So it's a basket of conditions, and we should be able to classify and identify where does she belong, because if it is preeclampsia, then it has immediate consequences in pregnancy for the mother and the baby, but also future consequences to mother's health. So the current status and the future means there are two areas which has drawn much attention in the last decade. One is about prediction. Prediction is important because there are ways and means by which you might be able to reduce the incidence of preterm preeclampsia under 34 weeks. And that gives a better prognosis for the mother and the baby. So that is why prediction is important, and also the possibility of prevention by calcium supplementation or low-dose aspirin. The second issue is about the long-term consequences, because the question arises whether preeclampsia precipitates a condition which is likely to come later on, like diabetes, gestational diabetes, they get diabetes later. So is it that it is going to predict the future likelihood of hypertension, or does it cause damage as well? That means while they are preeclampsia, we know in postmortems they get petechial hemorrhage in the liver, brain, kidneys, and so forth. So does it damage the organs, which adds to the insult of those who are already predestined to get hypertension later on in life? So these are things which you had to analyze. So let us go into classification. And if the blood pressure is elevated before 20 weeks and she has no proteinuria, then we should consider that as chronic hypertension or essential hypertension. And there might be an underlying cause like an endocrine disease. So you will have to identify whether there is a pathology behind. The second category is hypertension due to renal disease. Renal disease is not that uncommon. And example, glomerulonephritis in children. And when they become adult and pregnant, they might have hypertension. And in those, you get blood pressure before 20 weeks, but because the kidney is already affected, they have proteinuria before 20 weeks. So if they get hypertension and proteinuria before 20 weeks, then the question whether it's due to renal disease. Gestational hypertension is something which appears after 20 weeks without proteinuria, and it disappears after the pregnancy is over, maybe within the first 6 weeks after the delivery. Preeclampsia, on the other hand, comes after 20 weeks with blood pressure elevation, but also significant proteinuria. So it's a new disease which has come up, which proteinuria is because of the involvement of the kidney, but it can involve other organs as well. So this is the main classification on which I'm going to base my talk. So preeclampsia is a spectrum of pathology rather than a single disorder. So although we say proteinuria and hypertension, it can affect the liver, it can affect the other organs. So it is diagnosed when blood pressure is 140 or 90 or more after 20 weeks on 2 separate occasions at least 4 hours apart, or a single blood pressure reading of 160 or 140 or 120 with significant proteinuria. So proteinuria becomes the prime target, although some women with preeclampsia might have liver involvement with blood pressure, but not the kidney. So that's called atypical preeclampsia. So there may also be evidence of other end-organ disease. So if you find a woman with elevated blood pressure and proteinuria, it's quite important to investigate for coagulation problems and liver function. Edema is not a normal finding in up to 80% of pregnant women. So it tends to be most significant if severe or in unusual site. So preeclampsia can be suspected if you see facial edema or sacral edema because they are lying down, then that is likely to be due to preeclampsia. But pedal edema or leg edema is very unlikely. So the diagnosis is by mercury sphygmomanometer, which is a golden standard. But we don't keep mercury manometers anymore because of the danger of mercury. Other devices are now being used, but they have to be regularly validated and calibrated against a mercury manometer kept in the laboratory. The most important thing is to have the correct size of the cuff. There are 3 sizes of cuff, small, medium, and big, and you have to really select according to the arm circumference of the woman. And thirdly, you have to think about atypical manifestations with normal blood pressure. So sometimes if it comes with proteinuria, there's no blood pressure, it might be preeclampsia. We have to really check the liver function and clotting as well. So what is the etiology? Well, it is still not completely known. I think there are 2 phases. And first, it is disorder of placentation, which is failure of adequate trophoblastic invasion, which happens at 15 to 16 weeks. The invasion takes place even at 8, 9, 10 weeks with the chorionic villi, but deeper penetration into the spiral arterioles takes place at 15 to 16 weeks. Now, the overriding pathology is systemic vasospasm. And systemic small vessel abnormalities like microangiopathy due to increased endothelial wall activation of platelets and coagulation factors result in microthrombi and infarction of end organs. So what happens because the placenta doesn't invade the spiral arterioles? There is a factor which is released at the placental side, which increases the blood pressure in order to improve the circulation to the placenta. And this increase in blood pressure causes endothelial damage in different organs, initially with clotting, microthrombi, and then the endothelial itself can be damaged. And that leads to increased capillary permeability and movement of fluid into the extracellular space. So the first stage, we say two-stage disorder. Stage 1 is placental disorder because of pore invasion and release of vascular endothelial factors, which increases the blood pressure. Stage 2 is the maternal response. And the maternal response is partly based on placental issue, but also immunological and genetic. Like immunological, like antiphospholipid syndrome, women will have more tendency for preeclampsia. Genetic, if the mother or sister had preeclampsia. So it's a multitude of things, how the mother responds to the poor placental invasion. So stage 1 in normal pregnancy, there's a narrow, highly contractile spiral arteries in decidua basalis and myometrium, which are remodeled, which I'll show you a picture in a minute. And the extravillous trophoblast invades maternal vessels. These resulting wide bore, low resistant vessel delivers good amount of maternal blood into the retroplacental area. So much so, because of the low resistance circuit, the systemic blood pressure in the mother comes down a little bit. And this is to ensure adequate fetal nutrition and oxygen delivery. So it opens up the spiral arterioles or eats up the spiral arterioles to make a big lake behind the placenta. Failure to do so results in hypertension to maintain placental perfusion. So if chorionic villi don't invade the spiral arterioles, then it becomes a problem. So this is a classical picture, as you could see on your left, non-pregnant, the spiral arterioles are the same caliber from beginning to the end. If it is preeclampsia, because the trophoblast doesn't eat very much beyond the proximal part or middle part of the decidua, the lakes or blood lakes are very little. And normal pregnancy, the trophoblast has eaten through the decidua into the myometrial area of the spiral arterioles, making into wider channels. And that is the primary pathology. If it doesn't invade, then the blood pressure shoots up to pump more blood through the spiral artery into the system. Now, this can be identified when we do an ultrasound in the first or second trimester. So you find if there is both uterine artery, there are notches. There's a systolic flow, then the diastolic flow, there's a notch before that. Then it is very characteristic. There is a resistance, so it's pumping, but then it is relaxing. There's a drop, and then it picks up again. It can be measured by pulsatility or resistance index as well. So stage 2 is maternal endothelial dysfunction. So it is like an intravascular inflammatory response. There is some leukocyte complements and clotting system gets activated and increased permeability of the capillaries, and it reduces intravascular blood volume. So because it tends to leak and the vascular volume tends to get smaller. So increased vascular activity and vasospasm is the one which we try to make use of, the principle to reduce the incidence of preeclampsia. Because what happens, there is a balance between vasodilatory prostacyclin and vasoconstrictory thromboxane, and that causes the blood pressure to fluctuate. So unlike an adult like myself, the blood pressure will be elevated and constant now 3 months, 6 months time, whereas in pregnant mothers, it goes up at 9 o'clock in the morning, 12 o'clock it is back to normal, then 10 o'clock it goes up. This fluctuation is because of the balance between thromboxane and prostacyclin produced in the vessels. So thromboxane is predominantly produced by the platelets clumping up because of the elevated blood pressure, the platelets tend to become central because of the increased speed, and they break up and give rise to thromboxane. Whereas prostacyclin is also produced by platelets, but more is produced by endothelium. So the labile hypertension can be reduced by giving aspirin, 75 to 150 milligram in the night, because the aspirin reduces the chance of the platelets clumping together and breaking and releasing thromboxane. And it has to be given. So the action is only in the portal circulation. It is absorbed in the stomach as it is taken to the liver. It prevents the platelets from clumping together and releasing thromboxane. You cannot give high doses of aspirin because it will inhibit the endothelial release of the prostacyclin. So you have to give low dose, which is inhibitory to the platelets, and not high dose, which will cause the opposite effect. So 75 to 150 milligram is tried, and it seems to work well. So this is the two-stage disorder, and stage 1, and the mechanism why the blood pressure goes up seems to be release of soluble FLT1, cytokines, free fetal DNA. All this give rise to the problem. And stage 2, the maternal response, is endothelial problem, leaky capillaries, vasospasm, which affects the organs, kidney, liver, clotting system, and sometimes the brain as well. Now, the multisystem disorder is a problem because it is particularly affects the kidneys, liver, central nervous system. So kidneys, proteinuria, liver, abnormal liver enzymes, CNS, headache, blurring vision, convulsion, but also coagulation system, and also the placenta, where it can affect the baby. Now, the major problem we find clinically is to identify which organ will be first affected. Fortunately, most of the cases, the kidneys get affected first. The second problem is when and which other organs would be affected. Will it affect the brain, liver, and when it will affect it, and which organs will be affected is difficult to predict. And thirdly, once you know the kidney has proteinuria or liver has abnormal enzymes, how quickly they are going to escalate, it is difficult to predict. So therefore, it is important, if you're going to manage a preeclamptic woman, to monitor her blood pressure morning, afternoon, and evening, checking for the blood, the liver enzymes, and the renal function every day or every third day or every fourth day, depending on the severity of the disease, because we don't know which other organs are going to get affected and how quickly the situation is going to escalate. So once they get proteinuria, which means one organ is damaged, that means she needs admission to the hospital to monitor very carefully and to decide when to deliver, because if all the organ systems tend to go abnormal or clinically, the blood pressure is difficult to control. Systolic blood pressure is more than 160 despite multiple antihypertensives, then she might need delivery. So this is a major issue which you have to consider clinically: when to admit the woman, how often to monitor, and how to identify deteriorating condition. So this is in a diagrammatic one. Stage 1 is a placental disorder. Stage 2 is maternal response. Unfortunately, some of the mothers don't respond as an early preeclampsia. They present only after 34 weeks and more so at 37 weeks. So they are milder forms. So that is nothing very much to worry about. They can be induced and delivered. Whereas early onset preeclampsia can also give rise to growth restriction in the baby. In addition to the organ dysfunction we were talking about, it can affect the baby as well. So early onset versus late onset has consequences. Early onset is usually defined as preeclampsia, which develops before 34 weeks, whereas late onset is those who develop after 34 weeks. Both has important connotation for the current pregnancy, but also on the long term, once they are delivered, when they become 35, 40, 45, 50 years, 60 years as a mother, those who had early preeclampsia are more likely to develop hypertension and as a consequence, stroke and myocardial infarction much later. Now, abnormal placental development is believed to be more associated with early onset, whereas late onset is believed to be secondary to maternal microvascular disease or reflection of maternal genetic disposition. So it seems to be a combination of both with early preeclampsia, whereas The late onset preeclampsia has to do with how the mother responds to the condition. So in early and preterm preeclampsia, baby and mother are exposed to more complications and maternal mortality compared to late preeclampsia. The intrapartum maternal complications in preterm early preeclampsia are more severe because you might have to induce them. They can have a cesarean section, or they can have convulsions if the blood pressure is not controlled. And finally, the lifelong complication to the newborn and the mother, if there is like growth restriction, diabetes, obesity, and cardiovascular disease, are more prominent consequences in early preterm preeclampsia. Here, there are two issues discussed in that last bullet point. One is the mother herself is more likely to develop diabetes and hypertension and cardiovascular disease, but also the newborn. If the newborn is born preterm and also IUGR, this baby is likely to develop hypertension, cardiovascular disease, stroke when they grow up as adults. This is based on the Barker hypothesis. The smaller they are born, the greater the consequences in later life. It is because when they are born preterm and also growth restricted, the pancreas doesn't grow to the same size, the liver doesn't grow to the same size. So the pancreas, if it doesn't work because it doesn't grow, then it is likely they will get diabetes, and also the liver, it is unable to manage the glucose load, which adds to the problem, and so forth. So it's not only the mother, but also the baby, which has the consequences. So that is why it becomes important to treat before 16 weeks those who are likely to develop preeclampsia with 150 milligram aspirin. Some countries use 75, some use 90, some use 120, but 150 milligrams seems to be the maximal dose which you can go up to. And you can see on the table, if you see preterm preeclampsia, you can reduce the chance of compared to control, you can significantly reduce the chance of preterm preeclampsia, whereas aspirin doesn't have much impact on the development of term preeclampsia. So, but what we are worried is to reduce the incidence of preterm preeclampsia. So people have been working on how to identify based on clinical risk factors. Some are very obvious, like genetic factors. Women whose mothers have preeclampsia has 20 to 25% chance of getting preeclampsia. The sisters have preeclampsia has 35 to 40% chance. And obstetric factors like primiparity, adolescent pregnancy, multiple pregnancy, hydrops with a large placenta, hereditiform mole. Of course, that is not a pregnancy which will undergo, but they also present with preeclampsia. And medical factors, if they are pre-existing hypertension, renal disease, obesity, diabetes, antiphospholipid, they are more likely. So there are a set of clinical factors which you should be able to identify. Now, there are certain relative risk given to these factors, clinical risk factors. For example, age over 40, there's a twice the risk compared to a younger mother. Family history of preeclampsia, 2.9. Previous preeclampsia, 7 times the risk. So high BMI is a risk. Chronic hypertension and IVF is a risk. So with more than one clinical risk factor, there's a cumulative increase in the risk factor that can be calculated. If you use a formula, you can calculate a cumulative because she might be over 40, nulliparous, IVF, family history of PE, BMI might be over 35. So her odds becomes greater with multiple risk factors. In addition to the clinical risk factors, you can do physical parameter screening like uterine artery Doppler. And uterine artery Doppler is used as a screening tool mainly to predict those who are likely to get growth restriction and preterm preeclampsia. The prediction requires delivery before 34 weeks. Doppler at 22 to 23 weeks performs quite well with a detection rate of about 80%. So those who are likely to get term preeclampsia are not likely to be picked up, but they are not major concern. So this is about the notching and increased PI. You can take that into consideration. So the screening parameters, as we mentioned, is family history, medical history, genetic factors. Doppler of umbilical artery. But in addition, there are two other parameters which are taken into consideration in big centers. One is mean arterial pressure. The second is biochemical parameters. So if you take the mean arterial pressure, the best way to do that is actually to measure the arterial pressure on both arms using the appropriate cuff. As you can see, the third, and the woman should be seated and the arms supported at the level of the heart. That's the first point. Second, you have to select the right cuff, whether it's a small, normal, or large cuff, depending on the width of the arm or the mid-circumference. And then you have to rest her for 5 minutes and take the blood pressure and a series. And so that the last three readings are within 10 millimeter difference in the systolic and 6 millimeter difference in the diastolic. And then you calculate the mean arterial pressure by adding diastolic to the difference of systolic and diastolic divided by 3. That's the mean arterial pressure. And the arm with the highest final mean arterial pressure should be considered for risk assessment. So this is one parameter. And the nurses are trained to do this, and they will do that and give you the highest mean arterial pressure is on the right arm or the left arm, and this is the mean arterial pressure. Now, biomarkers is the other index we decided, and they have shown that combined screening may be more effective. And this is based on analysis of placentally derived peptides in the maternal serum. And this can be measured in the first trimester serum. And the common ones are PAPA, plasma-derived proteins, PP13. They're all low because the placenta is not functioning well. So they are low plasma proteins and so on. So you can develop a table like this. I won't go into the late details. First is placental growth factor, PAPA, placental growth factor with PAPA, placental growth factor, uterine artery, and mean arterial pressure. So if you look at that, if you put everything together, the last column, placental growth factor, PAPA, uterine artery, Doppler, and mean arterial pressure, that gives the highest prediction level. So this has been tried out, but new things are coming into play, especially what we call as SFLT1, which is a soluble FLT1, which is a splice variant of vascular endothelial growth factor, and circulating VEGF and PEIGF prevents their interaction to endothelial receptors. And that is also now used as a predictor. And increased levels of FLT1 are associated by decreased level of vasoendothelial growth factor, vascular endothelial growth factor, and placental growth factor. So FLT1 tends to go up. It's one of the powerful vasoconstrictors, and that is now being able to be measured. Now, however, although there are groups at King's College London and in Hong Kong and other places are saying that these are all predictable, this is a series of papers, 1, 2, 3, 4, 5. I won't go into the details. And they have measured, and they don't seem to get the same predictive value compared to some other groups. So in other words, it needs refining. For the time being, it is best to go, if you don't have the facilities for the measurement of blood parameters, then you can go by the clinical parameters. And that is what is recommended by the American College. And this is in 2013. Somebody asked, what is new in preeclampsia? They say neither first trimester serology screening nor second trimester uterine artery Doppler were clinically useful for predicting preeclampsia in the low-risk population. I would go one further and state, without some proven effective intervention beyond what we already have, implementing a screening test for preeclampsia is of minimal to no use. So it is interesting that there are people who are enthusiastic, whereas the others are very negative. So I think we had to work the way so that other groups can get the same predictive ability in their population. But the Royal College in the UK has recommended taking clinical parameters like nulliparous, BMI, previous preeclampsia, mother having preeclampsia, and so forth, and trying to calculate the risk of mother has some other medical condition, antiphospholipid, and to give low-dose aspirin. Now, the reason why we are trying to prevent early preeclampsia is because of the incidence of conditions which causes maternal and fetal complications, which may be avoided, like HELLP syndrome, hemolysis, elevated liver enzymes and low platelets, placental abruption, DIC, acute renal failure, pulmonary edema, aspiration, maternal death. So the incidence, as you see, is not high, but if there's early preeclampsia, then we had to say 1 in 10 might develop HELLP syndrome or abruption, and 1 in 20 might get DIC, and 1 in 20 might get renal failure or pulmonary edema, which has to be managed. So if you can avoid early preeclampsia, we can avoid the organ complications. Fetal complications, again, can be IUGR. About 5 to 18% might develop IUGR, and 30% might have to be delivered premature before 34 weeks because of the escalating preeclamptic condition, and perinatal mortality is also increased in these cases. So this is a diagrammatic way of looking at maternal issues. Vasospasm gives hypertension, vascular contraction, hypertensive encephalopathy, eclampsia, and sometimes cerebral bleed. And if it is causing petechial hemorrhages in the kidney, it causes glomerular disruption, proteinuria, edema, and renal failure. And microvascular damage can also happen in pulmonary vascular bed, and it can give adult respiratory distress syndrome. Hepatic, there can be petechial hemorrhage in the liver enlarges in size, and the liver capsule distends, and they get a hypochondriac pain, and rarely liver rupture has been encountered. And in the endothelium, it can destroy the endothelium and give rise to microvascular DIC and thrombocytopenia because the platelets get absorbed or utilized. Now on the fetal side, because of reduced placental transfer, there is prolonged hypoxia and reduced nutrition, which causes IUGR, which causes reduction in hepatic glycogen stores with reduced abdominal circumference, but redistribution to vital areas like the brain, sparing of head circumference. So it's an asymmetrical IUGR. If it is too much, then it can lead to placental death or acutely due to fetal abruption. And same on the fetal kidneys. If there is not enough placental vascular flow, then the baby might present with oligohydramnios and IUGR. So we'll move on to long-term consequences. We have looked at what happens in pregnancy. Well, the risk of developing gestational hypertension in a future pregnancy ranges from 13% and to 53%. So it varies quite a lot, how many can get gestational hypertension if they get preeclampsia. So preeclampsia in a future pregnancy is about 1 in 6 pregnancies. Preeclampsia is about 1 in 4 if they are complicated by severe preeclampsia. And if they are complicated by HELLP syndrome or eclampsia before 34 weeks, then the next pregnancy, they have a 1 in 2 chance. And also, it's greater if it is led to birth before 28 weeks. So the risk factors for subsequent preeclampsia is there even without any complication, but more so if it is delivered under 34 weeks. And if they develop severe preeclampsia, HELLP syndrome, then the risk becomes greater. And risk is 1 in 2 if the birth for complications is delivery before 28 weeks. So the long-term prognosis, so that's the immediate pregnancy complications in the following pregnancy. But the data are coming up now about it is not a benign and resolvable condition, but it has after effects. Not only it precipitates and show that this woman is likely to develop hypertension, but it can also cause damage in the meantime to the liver and the kidney, which can add to the problem of the possibility of the woman getting blood pressure, stroke, cerebrovascular, renal, diabetes, and cognitive dysfunction. For example, if we take death due to cardiovascular disease, it is 8-fold higher, as you could see here, if they get preeclampsia before 37 weeks. I can see the 2 tall blue bars on your right side, and you can see if they're born before 37 weeks, then they have preeclampsia, they have much higher chance of death. If there's no preeclampsia, then it is 2.95. But if they're born, the babies are born after 37 without preeclampsia, that's a standard 1. But if they develop preeclampsia after 37 weeks, it's 1.65. And delivering preterm itself is a risk factor. But if they have preeclampsia in the preterm period, then it becomes an increasing risk factor, about 8-fold. So that is why those who are preeclamptic in the pregnancy before 34 weeks need to have follow-up. So these are the list of illness the mother might encounter: cerebrovascular disease, stroke, thromboembolism, premature death, kidney disease, type 2 diabetes, thyroid, neurocognitive or psychological disease. And cancer, it's interestingly seems to be protected in some, but there's a question mark whether that's the case. Now, this is a complex table, but just to give you some idea of risk of developing disease after preeclampsia. And you can think about all the disease you want: ischemic heart disease, circulatory disease, premature death, non-fatal stroke, fatal stroke, venous thromboembolism, end-stage renal disease, hypertension, hypothyroidism. Everything seems to be increased. So in other words, the woman who had preeclampsia has to be checked every 6 months to 1 year, mainly for hypertension, because if you treat the hypertension, you can reduce the incidence of stroke or cardiovascular accidents and the mother dying early. Now, this is a graph which illustrates this very carefully. If you look at the vicious circle of preeclampsia, preeclampsia itself can cause cardiac changes, and that give rise to cardiovascular disease and also metabolic syndrome. But the graph on the right-hand side of your slide is more important. Survival percentage of mothers. If there are no preeclampsia and at a term delivery, they go on living for 50 years after the last delivery. The graph is given up to 25 years, but they go on living to 50, 60 years. So when they die, they are 85, 90 years old. But if they have preeclampsia and term delivery, they're not too bad. Preeclampsia term is not too bad. But if they are preterm delivery, even without preeclampsia, their longevity is reduced. But if they are preeclampsia and preterm delivery, it is shortened to somewhere near 30, 40 years. So they might die prematurely at the age of 55, 60, 65. Now that can be pushed back to the red line by identifying them, by checking the blood pressure every 6 months to 1 year after they are delivered, and giving them proper antihypertensive, anti-diabetic treatment. We can push it back so they need not die unnecessarily if you keep an eye on it. Now, the problem we are debating was preeclampsia and cardiovascular disease may develop by common pathophysiologic pathways initiated by similar vascular risks. So in other words, preeclampsia came on its own and disappeared, but has a common etiology. Or else, the second is the most important one, it may provoke permanent cardiovascular changes, which may be an independent contributing factor to the development of future cardiovascular disease. In other words, the preeclampsia itself damages the heart, the pancreas, the liver, everything, so that they are worse off compared to before they started pregnancy. So is there any proof to study that and to see whether there's a permanent damage? Well, Bhaskar Thilaganathan from St. George's, from our institute, has studied this. What he showed is actually the previous studies failed to differentiate between cardiac adaptations and myocardial damage. And he showed what is called as a type B cardiac failure, working with some cardiologists and doing tissue Doppler studies in patients who develop preeclampsia. And he showed that there is hardly any blood flow at the time of systole, and there is a dilatation or bulging of the septum, as you could see, failure to compensate, resulting in increased wall stress. And that time, there's blood not flowing into the myometrial tissue, and this might be a cause for concern, which gives rise to future cardiovascular disease. In addition, there has been this article about, and similar studies have been done, that when they do MRI pictures at 6 months, 1 year, 2 years, and the magnetic resonance imaging shows white matter lesions compared to controls, and persistent hypertension, if they have hypertension continuing after the pregnancy, then the white matter lesions are more. And some women, it disappears by 1 to 2 years, but some it continues. And this white matter lesion is correlated to dementia in later age. So preeclampsia causes a problem. The woman did not have white plaque lesions before, but she develops white matter lesions after preeclamptic process. So this is the details. Bottom line, if you read, preeclampsia may be a risk factor for permanent cerebrovascular damage. In addition, there is growing evidence that preeclampsia may be a marker of long-term health risk, that patients with a history of preeclampsia should be strongly encouraged to remain engaged, and preventive health care must be recommended all patients, but especially for high risk. So in other words, these papers repeatedly say that you can avoid the chance of the woman running into cerebrovascular or cardiovascular problem if you pick them up when they develop hypertension and treat them. So that is why long-term follow-up is important. Now in the offspring, I said about the Barker hypothesis, if they're born preterm and or growth restricted, they're going to be small and they are more prone to chronic lung disease, cerebral palsy, learning disabilities, type 2 diabetes, pulmonary hypertension, cardiovascular disease, because their organ systems are not well developed. So when they grow, they are more likely to run into trouble. But if they're born preterm, they are protected. If they're born at term, then they are not so much concerned with cerebral palsy because they are better off. But inflammatory, endocrine, and metabolic conditions will remain if they are preeclamptic, more so if they are preterm preeclamptic. So I wrote this editorial some time ago saying that obstetricians, perhaps it's time to change the lenses. In other words, our lenses or glasses or the way we look at pregnancy, we have been focusing on maternal mortality. Now that is coming down in many countries, including India. And now it might be an opportunity to look at, can we look after the non-communicable disease of women who are more prone to develop cerebrovascular, cardiovascular disease, diabetes, asthma, and so on, because they had preeclampsia to start with. So women with preeclampsia or growth-restricted babies are rarely considered to be at special risk until their next pregnancy. However, with women, pregnancies complicated with preeclampsia and IUG are at increased risk of developing chronic hypertension, diabetes, ischemic heart disease, cerebrovascular disease, kidney disease, thromboembolism, hypothyroid, and even impaired memory. So that really spells out the problem. The maternal preeclampsia is not a benign disease. It doesn't come and go after the pregnancy is over. It leaves a permanent mark in the mother's system to a lesser or greater degree, and more so if the preeclampsia developed before 34 weeks and the delivery is before 34 weeks. So in future years, it may be possible to offer women at 12 weeks gestation a combined screening involving quantification of angiogenic markers, ultrasound assessment of uterine Doppler. And there is another procedure which is evolving about capillary density using a microscope, which is non-invasive. So that might also come into force to predict those who are getting preeclampsia. So the future might be to consider aspirin and calcium because they are prone values, an agent capable of substituting for deficiency or inducing the hemooxygenase system. There are others in the pipeline like VEGF and L-arginine for treatment of preeclampsia because they think that might prevent as well as treat preeclampsia, and effects of supplementation during pregnancy of antioxidant vitamins and L-arginine. So there are a lot of research going on at the moment to avoid this complication of preeclampsia, which causes the problem. So the learning points are hypertensive disease in pregnancy, especially preeclampsia, is extremely variable in its presentation and severity. So it might affect one organ, 2 organs, 3 organs, it depends. Every year, several young and previously fit women die of preeclampsia. So we have to pick them up early And that is one of the main purpose of measuring the blood pressure. So if you don't have any predictive value or based on clinical history, mean arterial blood pressure, uterine artery Doppler, then it is more important for you to have regular blood pressure checks, especially if there's an elderly mother who is over 45, she's nulliparate, or BMI is high, or she has family history of diabetes, then you have to really bring them in. Once diagnosed, the disease will invariably progress. It doesn't get better, it gets worse as time goes on. But the problem is it affects different organs. We don't know when it will affect the second and the third organ, how quickly it is going to escalate. That is difficult to predict. And therefore, we have to monitor renal function, liver function, urinary output, the blood pressure, etc. The only cure we know is removal of the placenta. The pregnancy has to be terminated. So for that, we had to think of controlling the fits, controlling the blood pressure, and deliver. So because we want to achieve a longer maturation for the fetus, we continue provided there are no symptoms and the blood pressure is under control. And management should be multidisciplinary and evidence-based because you need the help of the anesthetist, the pediatrician, the midwife. So you have to really, once you diagnose preterm preeclampsia, you have to consult these people and let them know of the mother and should give the best care to the mother. Early prediction should be reproduced. In other words, I showed some papers from Australia which show some doubt about early prediction of biochemical parameters, whether it is useful or not, and how useful they are. But long-term consequence needed to be considered. So in other words, if you are treating a preeclamptic woman, then you should really think about how to look after her for the rest of her life, whether you want to bring her to your hospital or to refer to a general practitioner to check her blood pressure and diabetes and so forth, so that you give the best for her care. So I'd like to thank you for the patient listening and maybe pass you on to Sumita Roy. There are a couple of books which are available, High-Risk Pregnancy and Delivery, Southeast Asian Perspective, and Mandrako's Operative Obstetrics, which are edited. So they are with Elsevier, who are sponsoring this seminar. Thank you.
Thank you, sir. Can I now request you to please take up the questions from the students?
Okay.
I would also request the attendees to please post your questions now in the Q&A section.
Okay, so I'm going to a Q&A box so that I can field the question. So the first question is, how is preeclampsia harmful to the baby? Didn't understand. So the process is actually like a flow chart I showed you. The blood flow through the placenta is not enough in preeclampsia because there is the trophoblast hasn't eaten through and brought the spiral artery into arterial legs. So because the blood flow is not enough, oxygenation and nutrition going to the baby is not enough. So the babies present, some of the babies, 20% of the babies will present with intrauterine growth restriction. And you have to monitor them and monitor them with Dopplers, umbilical artery Doppler, amniotic fluid volume, and deliver them at the right time. If you don't monitor and if it becomes absent and then reverse umbilical artery blood flow, then they might die. So that is how the preeclampsia affect. That is the placental invasion into the spiral arteriole is not enough, and as a result, it presents as IUGR. The second mechanism is because preeclampsia is associated with abruption. The hypertension or the increased blood pressure which goes to the placenta tends to shear off the placenta. That causes damage to the baby. Second question is, what is IUGR? Sorry, IUGR is intrauterine growth restriction. So that the babies don't grow. Initially, the abdominal, if you measure symphyseal fundal height, it may not be growing. If you do an ultrasound, the abdomen of the baby is not growing, but the head keeps on growing due to head sparing effect. The abdomen doesn't grow because of the liver doesn't store enough glycogen because of inadequate nutrition. So intrauterine growth restriction is a possibility. and we have to monitor against that. Third is, if the woman is having any mood disorder and is taking treatment for the same, does it count as a risk factor for preeclampsia? Well, we don't know for sure. That needs further analysis. But based on the pathophysiology, the primary pathology seems to be invasion of the placental bed by the trophoblast and eroding into the spiral artery. So if the first phase is not there, then it doesn't give rise to preeclamptic process. So the mood disorder and treatment may not give rise directly to preeclampsia. So I don't think it's a major concern, but obviously it needs further study. What would be the best suitable definition for preeclampsia, hypertension with proteinuria, hypertension with end-organ damage? Well, that's a good question, and it needs both, in the sense you can use both as parameters, because if the hypertension with end-organ damage, proteinuria is an end-organ damage of the kidney, so that is automatically included. What they have found actually is not, although vast majority of them, the first organ seems to be the kidney. This might be because there is increased plasma volume in pregnancy by 40%, and the glomerular filtration rate is increased by 50%. So instead of 120 ml, it's 180 ml. So there's a, not only it's a preeclamptic process, but also heavy load for the kidneys to handle. And that might give rise to the proteinuria and detected first. But it can affect the liver, the brain, other organs as well. So because the severity keeps on increasing, once we get the proteinuria, you start checking for the liver function and also plotting dimensions to see whether it's affecting the endothelium elsewhere. Because if the endothelium is getting broken in other organs, the platelets are consumed and there is a minor DIC, and the platelet count will come down when you do a full blood count. So you do the full blood count, the liver function test, the renal function test, to see which organs are affected and how quickly they are going to escalate. So once you do, if they're normal, then you can do it in a week's time. If they're abnormal, you might do it in 3 days' time. But if they're abnormal and their blood pressure is going up, then you might have to do it every other day. Can microbial infection also cause PE in pregnant women? Well, not to our knowledge as microbial infection causes preeclampsia in pregnant women. About 20 years ago, there was a famous paper saying some sort of organisms causing preeclampsia, but it was never proven. It was a false hypothesis. So the preeclamptic process is because of non-invasion of the placental bed by the trophoblast and opening of the spiral arteries. Is PCOD a risk factor for developing preeclampsia? So this is a polycystic ovarian disease. So they have a, what we call as metabolic syndrome. So they might be obese and they are known to be a risk factor. To what percentage does it increase? I am not very sure. It depends on multiple other factors, because PCOD, they may not be young, they might be older, they might be obese, and they might have diabetes, or they might undergo treatment for IVF or other assisted reproduction and multiple pregnancies. So PCOD is a risk factor, certainly, but the degree of risk will depend on other factors as well, depending on the age, BMI, whether they shared assisted reproduction, and so forth. What are the manifestations when other organs are involved in preeclampsia? Well, the other manifestations are liver tenderness, which is the liver capsule enlarges due to petechial hemorrhages, headache due to vascular spasm of blood going into the brain, and clinically they will have hyperreflexia. So when you touch, the reflexes will be engaged. So in addition to, so if I'm going to see a patient in a ward with preeclampsia, I will draw a picture of the human being with the head, the neck, the heart, chest, arms, and so on. So I'll put an arrow to the arm and say blood pressure so much. I'll put an arrow to the liver and say liver function so much, kidney, renal function so much. So in other words, the manifestations can be variable. Some are picked up clinically, like headache, blurring vision, edema, atypical edema, and so forth. Some we have to test by measuring the blood pressure. Some you have to investigate. So in other words, your question is important as to what manifestations and other organs, but it cannot be clinical only, but it has to be clinical by examination as well as by investigation. What is the management of refractory eclampsia? So the refractory eclampsia, I think your status eclampticus, that's what probably is maintained. So this is quite an important area. It's rare, but it's quite important. That means they get a convulsion, you give magnesium sulfate, they fit again, you can give diazepam. And the best way to control if it is status eclampticus is to have an anesthetist and give anesthetic drug like phenytoin and control the eclampsia. Krishna Menon, who worked in Chennai or Madras in the past, has shown very clearly, it was one of the first few papers in the literature, that the incidence of maternal and fetal mortality increases depending on the duration from the eclamptic convulsion to the delivery. So refractory eclampsia means she's probably unable to be controlled and she has to be delivered. That's the definitive way of controlling the eclampsia. But initially, to get under control, to anesthetize, then you have to give you can try magnesium sulfate, diazepam, and phenytoin to control it. So that's quite serious condition if it is refractory or status eclampticus. Why should aspirin be given at night? Well, the studies have shown that if you give it during daytime versus nighttime, the effect seems to be better if it is given in the nighttime. There is no particular explanation given. Probably in the daytime we are consuming food and there is a lot of other issues related to the portal circulation. So in the nighttime, there seems nothing else but the aspirin, once it is taken, then it seems to work well. So it doesn't matter if the woman wants to take it in the daytime, the effect will be the same, but nighttime seems to have a little bit better effect. Help any good treatment, that is hemolysis, elevated liver enzymes, or low platelet. So there are many people who have tried various regimes. Obviously, the first things to do is to control the blood pressure and also see whether magnesium sulfate is necessary if she is hyperreflexic. Now, once they get help, they don't improve, they tend to deteriorate. And depending on how severe it is, that means whether it's partial or total help, because help is hemolysis, elevated liver enzymes, and low platelets. So in some it might be low platelets, some it might be elevated liver enzymes, some it might be both, some hemolysis as well. But if it's a total help or pure help, then steroids have been tried in what they call as a Mississippi regime, which has been tried in the United States. But there's no definitive, based on studies, there's no definitive way you can control it. So you can try, but the best is to control the symptoms, bring down the blood pressure, prevent her having eclamptic convulsions, and monitor her. And if the maturity is such enough, then you have to remove it. Pathology of preeclampsia and heritiform mole. We don't know the pathology per se, but the theory seems to be that the placental factors which give rise to, because heritiform mole, you don't get amniotic fluid or fetus there. So it's all placental tissue, so it invades into different areas. And that might give rise to some chemical. We don't know. They say the HCG level has some role, but it is not very clearly understood. For example, multiple pregnancy have a high HCG level, and it comes down after the first trimester. But in heritiform mole, till it is evacuated, the various enzymes or vascular growth factors all are modified, and that might be the reason. I wouldn't be able to tell you exactly what is the reason for preeclampsia. Wherever there is a increase of placental mass, there is incidence of preeclampsia. Another example is patients with alpha thalassemia. That's very common in Singapore, Hong Kong, that area. And the baby is hydropic and the placenta is also enlarged. And they come at 28, 30 weeks with severe edema and proteinuria and hypertension. And of course, you have to deliver because alpha thalassemia is non-viable fetus with hydrops. So increased placental tissue, placental mass, seems to give rise to a preeclamptic process. What is the role of calcium in the management of preeclampsia? So the calcium is given only in patients who are living in calcium-deprived area. This starts from the Amazon jungle story of Puma Indians who cook their food in pots with lined with lime or calcium, and that population doesn't get preeclampsia. So they have shown by clinical trials it doesn't help in every, like a well-developed country where they consume calcium in the way of cheese and milk and so on. But where calcium is deficient, substituting calcium and prevents the occurrence of preeclampsia. This might be because the vascular endothelium or vascular spasm is in some way controlled with adequate calcium. So there are trials to show it is useful. Will the dose of aspirin vary according to patient's weight? That's a good question, but generally we find that aspirin is available in different countries at different doses. And in America, they use Cardiprin, which is about 90 milligram. In UK, they use 75 milligram. The lower the woman's weight, probably she will need lower weight, but there's a range. So you can give 75 to 150 milligram. If you give 300, which is a standard aspirin dose, it might be a bit too much, and it might inhibit the functioning of the endothelium as well, which might prevent prostacyclin release and vasodilatation. So low dose aspirin, 75 to 150 seems to be okay. Some believe it should be 150 milligram, but I think it should be okay either way. Can you explain about capillary density, which you touched upon being a non-invasive early test for preeclampsia? Well, there's been some studies shown in St. George's by Isaac Manyonda and Vikram Taleluka who studied, and there's a similar to an ultraviolet light, which can be shone on the skin. And the capillary density tends to vary in those who are likely to get preeclampsia opposed to those who are not going to get preeclampsia. And the condition reverses as time goes on. And they have shown that if there is increased capillary density, then there is less chance of getting preeclampsia. And if it doesn't form increased capillary density, then they are the most likely candidates. But it is a preliminary stages, so we need further study how to look at capillary density. It is just not an invasive test. It is just shining a light. Under a microscope, you can see how the capillary density is and then deciding. What is the frequency of occurrence of cerebral palsy in such mothers? Well, cerebral palsy is not in the mother. It is actually in the baby due to growth restriction, unless the mother gets a stroke, of course. But cerebral palsy, by definition, is a motor disorder which doesn't progress. So if the baby has IUGR, and if you don't deliver them in time, or if the baby gets asphyxiated, then the baby might get cerebral palsy. The incidence is very low because I can't give you a pinpoint incidence. It can vary from country to country and place to place, but it is a well-identified risk factor. If the preeclamptic IUGR baby is not delivered in time, then it might affect the brain. Initially, it affects the abdomen, the liver size, then the brain sparing effect goes on. But if it is not delivered in time, it might cause problems to the brain as well. What is close monitoring in preeclampsia? What is the indications. Could you please explain? Yeah. Close monitoring means to check the blood pressure, reflexes, the urine protein, and also the blood test. And this blood test is, we call it PET blood. That is a full blood count, renal function, liver function, and coagulation screen. So how often you do it will depend on how bad the preeclampsia is. If the blood pressure is uncontrollable or difficult, then you might do it every day, every other day. And so two parameters will decide how often you're going to do it. First is, what was the results today? If it is abnormal, then I might, and it has jumped from 6 to 10, then I might do it tomorrow. But if it has gone from 6 to 7, then I might do it third day. So you have daily or every 3 days. If you are doing every third day, you plot the parameters and how quickly these enzymes or hormones or whatever it is changing, or platelets are changing, we will try to do it. That is close monitoring. So close monitoring of clinical parameters is on a daily basis, 4 times at least the blood pressure. Urine protein, you can do it on a daily basis, once a day. Whereas the chemical parameters or hematological, the full blood count and the other, depends on how abnormal the tests are. If the abnormal is remaining, then you have to do that. Difference of eclampsia and preeclampsia and simple term. Eclampsia is limited to one condition where the mother is fitting convulsions. Preeclampsia is the mother who has proteinuria and hypertension. Most of the eclamptic women will have preeclampsia, not all of them, but eclampsia is due to convulsions due to the raised blood pressure. Preventive strategies for preeclampsia. Well, as I mentioned, you have to screen them clinically by clinical parameters and give low-dose aspirin and calcium. These are the preventive strategies. There are others which are coming into play like L-arginine, but we don't know. But for the time being, low-dose aspirin after 14 to 16 weeks till about 37 weeks, and calcium about 500 milligrams daily. What was the hypothesis that predicted the premature babies have more incidence of occurring cardiac? And why does this happen? Well, the hypothesis is called Barker hypothesis, B-A-R-K-E-R. So if you type in the Google Barker hypothesis, then it'll tell you all the story about Barker, who is an epidemiology professor from Southampton, who went and saw that babies born with a low birth weight died early due to cardiovascular or cerebrovascular disease. And the same observation was observed in Sweden, in Denmark, and Netherlands, and so on and so forth. And the hypothesis behind Barker was that if they are undernourished when they are in the uterus of the mother, then their liver, their pancreas, their heart, their blood vascular system don't grow. So when they don't grow, when they grow up, the pancreas doesn't secrete enough insulin, so they get diabetes. The liver doesn't function, so they have other problems, and the vascular system is not functioning. So that is called X syndrome or Barker hypothesis due to undernutrition. Now they know that it is not only the poor nutrition and the small birth weights, but also the lack of nutrition, and in fact even breastfeeding, etc., can influence what we call as epigenetics. So we don't call it only due to fetal problems, but we call it a growth disorder problem from childhood. So the first 1,000 days seems to be quite important from time of conception. So 360 into 3, which is 1,000 days, 3 years, is important. Can a preterm baby is born at a non-preeclampsia mother at high risk of diabetes and other endocrinal disorders compared to term baby? Well, the hypothesis seems to be that preterm babies have a risk, IUGR babies have a risk, but not to the same degree like if they're born preeclampsia and preterm. So if they're born preterm due to preeclampsia, they are at a higher risk compared to those who are born preterm without preeclampsia. Could you brief us serial Doppler changes in preeclampsia? Well, the Doppler changes I mentioned is actually the uterine artery Doppler. Either you get notching or elevated resistance in the uterine artery to predict. But while you're monitoring an intrauterine growth restriction, then you can have high resistance of pulsatility index. Then the Doppler will show end diastolic flow, the diastolic flow getting less and less, and end diastolic flow absent. And then you get reversal of end diastolic flow in the uterine artery. So when it becomes reversal, then you have to deliver that baby, even though it might be at a preterm period. What is appropriate term? IUGR or fetal growth restriction? Both are used loosely. One is intrauterine growth restriction, the other one is fetal growth restriction. Both means the same. Both terms are used interchangeably. Is it possible every woman will have preeclampsia? Not all the women, only 10%, 8 to 10% get preeclampsia, 90% don't. So not all of them, not all women will get preeclampsia. Is preeclampsia a protective factor for cancer endometrium? We don't know. We don't know. The answer is we don't know the answer. The preeclampsia has had some impact saying on cancers, but it is not proven. Can any surgery be done to prevent this condition of preeclampsia so that enough oxygen and nutrition be supplied properly? No, there's no surgery because this is the placental uterine interface, so nothing can be done. Medically, that is why low-dose aspirin is given to prevent clotting of the vasculature. Are there any other drugs for preeclampsia treatment? Well, there are antihypertensive treatments like labetalol and magnesium sulfate to prevent the convulsions and so on. There's no specific drug, although L-arginine has been tried recently.
Sir?
What?
Hello? Am I audible?
Yeah, I can hear you.
Sir, we are already ahead of time, 10 minutes overdue. So would you like to take a few more questions or should we conclude here?
Yeah, we can, maybe I'll take the last few to see.
Sure, sure.
Okay, this is going on and on, the questions. I think it's difficult to answer all the questions. So.
Yes, it is a very interactive and interesting session. I can see that.
Okay. So we might have to stop there, and thank you for the kind participation. I'm sure if you read the book High Risk Pregnancy, there are chapters on preeclampsia, and that'll give you the answer. So maybe the Elsevier can help you with the book. Thank you.
Thank you, sir. This was a really interesting session. I am sure all the students have really gained from this. I can see more questions coming in, but in the interest of time, we have to conclude the session. Thank you all for your attention and participation today. Have a very good evening.
Thank you, and thank you very much to all for participating. Thank you very much. And good luck with your exams and your practice.